I'm getting one more chance. I have the same reason to explain you again. Anyways, I'll start with this presentation. Yeah, the presentation before I start, there are a sequence of the publications which explain that micrometastasis takes place during vessel ligation and what impact it goes through. The sequence of vessel interruption during lobectomy, there is a publication from Israel which says that when the vein was ligated first, there was an increase in the congestion and the size of the lung increased, and there was a difficulty in operating. But they didn't explain what was the time between ligating the vein and ligating the artery. And after the study, what they had, they drained the blood. How much the blood was drained, they had not specified, but the amount of blood was not specified. But this is what discussed in the study. The objective of his study was to assess the influence of the sequence of pulmonary vessel ligation during anatomical VATS major pulmonary section and survival of the patients with lung cancer. There were 3 groups: patient who had all major lobar arteries stapled before lobar veins, reverse vein before arteries, and mixed group where arterial branch followed by vein. What method? This was a retrospective study, again, was from the data set. So what he adopted is a basic demographic, surgery required, operative time. And what major importance he gave was a conversion, readmission within 2 weeks, and overall survival. This is the result, what we see in this. And the most important part was follow-up was in vein ligation first was minimum. The results in 30 days mortality, none of the cases had 30 days mortality. But the most important thing, readmission was minimum in group C. That is a mixed. Conversion rate, again, was minimum in the group C. The Kaplan-Meier survival chart shows that all the three groups has same results of survival in 5 years. The sequence of vessel interruption in VATS lobectomy for NSHC does not affect overall survival. It does not increase the level of difficulty of the operation. Lobe congestion was not a problem. Take the easy vessel first, might influence the conversion rate and improve outcomes.
Thank you. Questions?
I have one question. I may not be able to make it to Berlin next year. Are you available for a few presentations I might have?
I think I would buy a contract now.
Okay.
Dr. Hammer, why do you think the conversion rate was so high, up to 65%?
In the
vein before artery?
Because they adopted the Fisher first approach. And the Fisher, they had the chances of encountering the artery, and majorly because of the dissection. And the learning curve was on the same side.
So they approached the Fisher differently, yeah, whether they were going for the artery first or the vein first?
Dr. Emmer adopted was a Fisher approach. That was arteries.
I see. And for Dr. Oliveira, do you find that the exposure, I do medical thoracoscopy also, do you find that the exposure is always good and the movement of the diaphragm doesn't sometimes affect your visualization?
Yes, of course. I have to learn how to reduce my presentation. It was my PhD thesis. And it was, I have a lot of movies of my cases, and it was the same presentation. The goal that was reached was to put the patient at the level 5 and Russell scale sedation, around this. Because something above this, you can get the general anesthesia. You probably need the tracheal intubation. But the exposure was very good. The respiratory frequency was around
or pneumothoraces and just one mediastinal tumor. I don't know if you've done other cases, but in terms of lung collapse, how much of a problem is that? I'm assuming with the effusions and pneumothorax, the lung collapses because it's already collapsed. But what happens in the cases where you...
Are you talking about the mediastinal tumor?
Well, when you have the lung inflating in your face all the time and the patient's ventilating?
We have just one case.
Can you please use the microphone so we can get it on?
In this case, the tumor was huge. I didn't have any trouble with the lung insufflation. It was very easy. And the patient wasn't in the lateral decubit in this particular case. The patient was in pronate decubit.
Supine?
Yeah, supine decubit.
Okay.
Exactly.
Okay. Is anyone else doing awake thoracoscopy? And are you doing it for cases where, I mean, like a lung biopsy and those kinds of things?
I don't do it for lung biopsy, but I do it for pleural biopsy, pleurodesis, sicker patients.
I've been doing it for patients who are really not intubated with the risks of prolonged respiratory support. So it's a very small select things we work out.
Yeah, for the study, we couldn't select the patients. We have to get all of the patients in the sequence that appear. But the idea of the study was in our oncology office because we had a lot of patients in critical diseases. And when you're talking about to make some procedure in pleural cavity, every time they're thinking about to be intubated and then general anesthesia, and they're afraid about it.
Hi, I'm Elizabeth Klein from Charleston. A couple of years ago, I don't remember who presented, doing a fair number of things with local anesthesia and sedation. And I came back and asked the anesthesia guys if they'd work with me. And so for about 2 years, I've done all my malignant effusions with local anesthesia and sedation. And it's hard to tell a patient for a palliative operation, I'm going to put you on the ventilator and you may not separate from the ventilator. So that was really one of the driving reasons. And then the other one is they recover so much more quickly and they don't go to the ICU. But I tell patients I have to work a little slower. Those are like 15-minute operations when the patient's asleep, and they're about maybe 25-minute or 30-minute operations when they're awake. I use rib blocks for everything. And then the Pleurex kit has some sequential dilators. So I end up I put those in sort of Seldinger, and then I use that largest dilator through my trocar when I put my first trocar in. We use insufflation and haven't had any trouble with visualization. Sometimes the patients react when the talc goes in. They cough a little bit, but it's really, it's changed what I do, and I do that. That's my routine now. And like I said, I was a little bit put off by people talking about it a couple years ago, but I came home and tried it, and we really haven't turned back. We've been very happy. So.
Thank you.
Thank you.